one, just because it tends to be the most common one globally, and we'll talk about why that is, and we got to talk about a condition kind of leading up to that before we jump into the mitral valve for today. Now remember, we talked about, when you talk about valvular heart diseases, there are the regurgitation murmurs and there are the stenosis murmurs, right? And if you remember, we said regurgitation murmurs are present when you don't get a good seal of the valves. So you get a backwards flow of blood. So instead of having that one-way directional flow, you now are having two directional flows. And it's because those valve leaflets don't seal and close properly. Now when we talk about stenotic valves though, however, this is that resistance to opening because of calcifications, hardening, stiffening of the valve leaflets themselves. And now you start to have that resistance to opening, which then delays the actual flow of blood, and then it leads to higher pressures required to actually open those valves to get that flow of blood going. If you like mnemonics, and you want to try to remember which murmurs cause systolic murmurs, the mnemonic Mr. Passman's Most Valuable Player can help you recall all of the valve pathologies that cause systolic murmurs, okay? If you like, on the other side, diastolic murmurs, Ms. Arts helps you differentiate those that cause diastolic murmurs. But a simple way to remember it is, if that valve should be open during that phase, then it's a stenosis murmur. If that valve should be closed during that phase, whether it's systolic or diastolic, then that is a regurgitation murmur. Okay, so if closed, it'll be a regurgitation. If it's supposed to be open, it'll be a stenosis murmur. And recall from our first block that each one of these murmurs is best appreciated at a specific auscultation site. And knowing which auscultation site is present and what phase you're hearing the murmur will help you diagnose the heart lesion. Also recall from block 1 where there's a certain grading system when you try to describe the murmurs. And you got to remember, systolic murmurs are not graded the same as diastolic murmurs. So when you say this is a 2 out of 6 systolic murmur, there's a specific thing that you're trying to convey to folks coming after you reading your note. So that way, if they follow up and now they say this is a 3 out of 6, then you know that the condition is getting worse. Okay? So you got to know what exactly you mean when you say this is a 2 out of 6 or a 3 out of 6 or even a 6 out of 6 systolic murmur. And knowing and being able to classify these murmurs is important because this flow chart kind of is a little maybe difficult to look at, but ultimately, if you know certain things and you can grade the murmur intensity properly or appropriately, you can, simply before doing an echo, be able to differentiate benign murmurs versus pathologic murmurs, okay? Pathologic murmurs, if it's diastolic, all diastolic murmurs are pathologic, okay? So if you have a diastolic, it's pathologic. If it's pansystolic, so it goes, or holosystolic is the other term for it, that is also pathologic. If it's late systole, that's pathologic. Loud murmurs, so grades on the systolic side, grades 3 to 6 is there. Now you may be wondering, okay, but diastolic murmurs aren't graded on a scale of 6. Where's the diastolic murmurs? Well, go back to point 1 where all diastolic murmurs are pathologic. Okay, so we don't need to grade out diastolic murmurs to be able to differentiate benign or pathologic because all diastolic murmurs are pathologic. And then if it's continuous, meaning full duration of systole and diastole, that is also a pathologic murmur, regardless of whether or not you do an echocardiogram. If in question, you can always do an echo. Okay. Now, depending on the heart murmur you have, there's going to be a specific configuration pattern to it. And if you remember from block 1, configuration refers to that change in intensity over time. So you get a little unique shape to that murmur depending on the murmur that's present, okay? And we'll talk about each one of these murmurs and why you see this kind of specific pattern in their configuration. Meaning, like on the first one, this crescendo where it gets louder, and then that decrescendo pattern where it gets softer over time. Okay, we'll talk about why each one of these valvular diseases has this unique configuration. But before we jump into the specific valvular lesions, we've got to talk about acute rheumatic fever and rheumatic heart disease because in the industrialized world, this is a very rare thing. But in global communities, this is the most common cause of valvular heart disease. Okay. And being military members, where are we deploying to? Industrialized nations or underserved nations? Typically underserved, whether it be a combat role or in a humanitarian role, right? The Navy's always sending our hospital ships doing humanitarian missions, hearts and minds with our allies and stuff like that, both in the Pacific and in the Caribbean. The populations that those missions are going for are going to be dealing with this condition. So this is one of the reasons why, even though in the United States and in our textbook it dedicated only one page to discuss this, we are going to go a little more in depth on rheumatic heart disease, rheumatic fever. Okay. So what exactly is this? It's a constellation of symptoms, but it's a progression over time of a strep throat infection. Okay, strep throat in the United States is super common, right? When you start working in your pediatric clinics, every other patient you see is probably going to be strep throat, right? Well, we normally don't think too much about strep throat other than it's painful to swallow, here's some antibiotics, you'll get better. But the concern is, if that goes untreated, whether it be they never presented you to healthcare, there's no access to healthcare, or there's no access to antibiotics, then this becomes a problem because it can progress to a chronic disease. Okay. And we're going to talk about, I mean, you should all know about, strep tonsillitis and the symptoms of that and everything like that. So we're not going to really focus on that, but we're going to focus on the step 2 and step 3 of this progression because it relates specifically to the heart. So acute rheumatic fever typically develops within 2 to 3 weeks of a strep throat infection. Typically, that is untreated with antibiotics. Okay? So this is not something that develops immediately after. There is a 2 to 3 week delay in the development of this condition. And it starts to attack multiple systems, but heart valves tend to be one of the more common sites of its attack and its effects. And you can see mitral valve tends to be the most common valve impacted by this complication of an untreated strep infection. Okay. And then it can affect other valves. You can see aortic valve in 20 to 30% of patients. Even the tricuspid valve can get impacted by this, but it is rare. Okay. But the mitral valve is most common, with the aortic valve is second most common. But you can see this condition is 19 times more common in underserved, non-industrialized nations versus industrialized nations, because we typically do have access to care and we have access to antibiotics to treat these things. Okay. And the biggest thing that you can do to lower the risk of complications developing from the strep throat infection is simply giving them an antibiotic that treats strep adequately. So your penicillins or the equivalents that can treat strep. Okay. Acute rheumatic fever, think of the population that's more prone to getting strep throat, right? It's going to be your younger to adolescent, your younger pediatric to your adolescent range. So 5 to 15-year-olds are the ones who are going to be more likely to develop this condition, because that's the population that's more likely to get strep throat. Okay. And when they present with these symptoms, it could be initially just some vague symptoms of an infection. Okay. I have a fever, I'm fatigued, I have chills. How many pathologies have you studied that have those symptoms correlated with them, right? Too many to tell, or too many that you can't use this to help differentiate what is going on, other than the fact that there's probably an infection going on somewhere, okay? But what's interesting about acute rheumatic fever is there is actually a constellation of symptoms that is more unique to this condition. And you can apply the Jones criteria to help you differentiate acute rheumatic fever from other causes of infection. Okay. And when we talk about Jones criteria, similar to like when we talk about modified Duke's criteria for infective endocarditis, the criteria is, well, one, I need to have a history, especially recent history, of strep. If you have not had a strep infection recently, you cannot have acute rheumatic fever. Okay? So you have to have that history of strep. Then, once you've delineated that they have had that history of strep, then to be positive according to Jones, you just need 2 major criteria or 1 major, 2 minor. Okay? We'll focus on what the minor ones here are on this slide, and then we'll go through each one of the major criteria individually to kind of explain what we're seeing with those. But looking at the minor criteria, okay, arthralgias, fever, elevated ESR, CRP, okay, not specific. So you can imagine, if I just have 1 major criteria, to get to that criteria of 2 minors, it's pretty easy, right? They've got a fever and they have elevated ESR, CRP because they have that acute phase reactant or that inflammatory markers are elevated, right? You may also see a prolonged PR on the EKG, okay? But let's look at the major criteria on the Jones criteria to help us differentiate this from other pathologies, okay? Fortunately, if you change the O in Jones to a heart, the name can help you remember what the major criteria are, okay? So J stands for joints, so you get this migratory polyarthritis where major joints suffer pain, okay? So you're talking about your knees, your elbows, your hips. These are joints that are going to be affected by this inflammatory process. And it's extremely painful. There is swelling and erythema involved. You may even be suspicious of a septic joint. But this is something that will, if we don't do any treatment for it, will resolve over time but it may take a month for it to go away. Okay. So that's the J in Jones. The O change to a heart is carditis involvement, where basically the reason you see this is there's a cross-reactivity, and kind of think of this as like an autoimmune reaction between the antigens of the strep bacteria and the antigens of the heart structures. Okay? So you get an autoimmune reaction, the body thinks it's fighting strep, when in actuality it's binding and attacking your own heart structures. But this can lead to an inflammatory response being present to all three layers of the heart. So it may even mimic a pericarditis kind of picture, because the pericardium, which is also known as the epicardium, becomes inflamed. So you may have that friction rub. You may even have some of the typical EKG changes associated with a pericarditis. Okay? But it does tend to attack the valves, the mitral valve being more common, and this can then start to affect the actual function of the heart itself, because these valvular lesions, these valvular pathologies, have a secondary impact on the actual function of the heart. So it may start to interfere with the ability to squeeze the left ventricle appropriately. So now you start to get a decrease in the forward flow, or that cardiac output, and now you start to get a backup of fluid into the atrium, which then goes into the lungs, and now you're looking at more of like a heart failure kind of picture with these things. But because you have this inflammatory process as well, that's going to interfere with the function of the valve, so you can hear the murmurs, whether it be regurgitant or a stenotic murmur. You can hear this on auscultation. But at this time, in the acute rheumatic fever phase of this progression of symptoms, this is transient. So you're going to hear the murmur, you're going to treat the condition, the inflammation is going to go away, those murmurs go away at this phase. Okay? So it's transient in nature. Continuing on, so N stands for nodules. So you're going to have these subcutaneous nodules. And this tends to be one of the least likely symptoms in the major criteria. Okay? And these are painless subcutaneous nodules, so which can help you kind of differentiate from other subcutaneous nodules, the fact that this is a painless kind of thing. And then you have the E, which is erythema marginatum, which, looking at this rash, it kind of looks like a fungal infection, doesn't it? Jock itch, tinea corporis, wherever the infection, the fungal infection is, you can throw on different terms for it. But this kind of looks like a fungal infection. But what happens with fungal infections, symptom-wise? Itchy, right? This is a non-pruritic, non-itchy rash, okay? And I've seen cases of jock itch before where they're like, oh, no, I'm fine, doesn't itch, and then they start sweating and then it gets itchy. This will not get itchy, okay? So it looks like a tinea infection, but it doesn't have the typical itchy symptom with it. So be suspicious, especially in a younger patient, if you see this rash for acute rheumatic fever. And then probably the most pronounced symptom, or maybe the most disabling symptom, is this Sydenham's chorea. Okay? There are other like movement disorders like Huntington's chorea, Parkinson's, where you develop this involuntary kind of quick motion tic, and people will lose control over their extremities and even their head with this condition. Unlike some of the other movement disorders, though, this one tends to go away during sleep. Okay? So you don't get this abnormal rhythm tick movement when they're sleeping. And this usually lasts anywhere from 3 to 6 weeks. So this will go away. This is not a permanent thing like Parkinson's and Huntington's chorea and those kinds of things. This will improve and this will go away. But you can imagine for that 3 to 6 weeks that they're having this symptom, how impactful to their life is this going to be? Okay. And that's present in about 20% of patients with acute rheumatic fever. Okay. So we talked about, according to Jones, you have to have that evidence of a strep infection. So how can you, or what would qualify for evidence of a strep infection? Well, the same tests that we use in the acute strep infection we can use. So rapid strep tests, positive throat cultures. So those could be adequate to prove that they've had it. But what happens if they come to you 2 to 3 weeks after that infection? And now you try to culture the tonsils and you're not getting and detecting that strep. What else can you use to help you show that there was evidence of a recent infection? And the answer to that is antibody tests, right? Look at the titers and those types of things. And there are specific ones like the anti-streptolysin O, the anti-DNase B, and the anti-streptozyme tests in particular that you can use that will look for evidence of a recent strep infection, okay? So if your rapid strep is negative, your throat culture is negative, but you still are highly suspicious that this patient is having acute rheumatic fever, maybe let's go do the antibody test because it may be too far removed from that infection to be detected on those more of acute kind of tests, okay? So use the antibody tests to help you. But if you're still not sure and you feel a little adventurous, you could obtain a cardiac biopsy. And when they look under the microscope in the setting of acute rheumatic fever, you're going to see these things called Aschoff bodies being present. Okay, so when they look under the microscope, they'll see these things there, and that can confirm your diagnosis. But fortunately, we don't necessarily need to do cardiac biopsies to diagnose this condition. Okay. So how do we treat acute rheumatic fever? This is a thing from strep throat, especially a untreated strep. Well, does it make sense that probably we should then treat it with antibiotics that are adequate to eradicate strep bacteria? Okay, so we gotta give them antibiotics. But this is also an inflammatory condition, and we have to give them anti-inflammatories as well to calm down that inflammation so that the body can recover. And typically, we give aspirin for these cases, and we give high doses of aspirin, okay? And the question I always get is, oh, I see aspirin in children, aren't you concerned about Reyes syndrome? And the answer is, it's a risk-benefit decision. The risk of Reyes is a lot less than the risk of complications related to this infection. So that cost-benefit analysis is, let's give them high-dose aspirin to prevent further complications developing from this condition, okay? So high doses of aspirin. It's not important for you to remember the range or the dosing. I put it on there just to show you that this is not a 81 milligram dose of aspirin, they're baby aspirin, and that's it. And this is also a lot more than we give of aspirin for somebody with acute coronary syndrome, right? We usually give them about 325 milligrams of aspirin to chew, and we're talking about 4,000 to 8,000 milligrams of aspirin a day to treat this in an adult. So mega doses of aspirin. But does it make sense also that if you've had acute rheumatic fever once, that if you get another strep infection in your future, that you're going to be at a higher risk of developing acute rheumatic fever again? And the answer should be yes, right? And unfortunately, these patients are going to need prophylactic antibiotics for a period of time. And I put down it could be anywhere from 20 to 40 years that they're going to need prophylactic antibiotic, or sorry, they could be until they're 20 to 40 years old that they'll need prophylactic antibiotics, because we don't want them to ever have another strep infection leading to the development of acute rheumatic fever. Because maybe we have delayed that progression to the chronic version that we're going to talk about in that rheumatic heart disease, but if they have a subsequent infection, then they're at a much higher risk of developing that chronic complication. So what do we look for, or what can we do from a prophylactic antibiotic standpoint? Well, it could be that they take a daily penicillin pill. That's not necessarily convenient, right? So, but you can do daily PO, or you can do a monthly IM shot of penicillin G. So compliance is probably going to be a little better by doing the monthly shots versus a daily antibiotic. Okay? But we do this because we want to prevent that progression to the rheumatic heart disease, which is a chronic problem, and this is a permanent damage. Okay? We said you have temporary damage during the acute rheumatic fever phase, but when they progress to rheumatic heart disease, this is now permanent. We can't do anything to fix it necessarily without doing invasive treatments, okay? And when you get chronic rheumatic heart disease, this is typically anywhere from 10 to 30 years after they had acute rheumatic fever, okay? So we said the age most likely to get acute rheumatic fever is 5 to 15, right? But now we're saying 10 to 30 years after that is typically where you start to develop this acute, rheumatic heart disease. So now you're talking about 15 to 35-year-olds is when this chronic heart disease develops and presents. Okay. The news story highlighted that. If you caught it, it said that she had acute rheumatic heart disease at the age of 20, prompting the valvular replacements. At 20, you're seeing this because it falls into that 10 to 30 years after the acute rheumatic fever that this complication develops. Okay? Mitral valve is the most common valve affected by this, aortic valve being number 2, and then the tricuspid valve being number 3, but is still rare. And the damage that occurs could be a regurgitation murmur and or a stenosis or stenotic murmur, okay? And we're going to go through now and start looking at all the individual heart valves and the type of pathologies that you can see, okay? So we're going to start, and we're only going to do the mitral valve this lecture. We're going to do the other 3 tomorrow, okay? But we're going to do the mitral valve today and finish up. So when we look at mitral stenosis, this is typically more affects females more than males, and it tends to be in a younger age in your under-industrialized nations. Because remember, the most common cause of mitral valve disorders globally is rheumatic heart disease. And the most likely and more the population that's most at risk of developing that is the under-industrialized, underserved countries. So it tends to be younger in there than in industrialized nations, where it tends to be a much older population that develops this mitral stenosis. And if you look at the etiologies, it'll make sense why we see kind of those two patterns, okay? So the number one cause globally is rheumatic fever, rheumatic heart disease. After that, now we're looking at congenital stenosis. So, you know, they were born this way. Severe annular calcification. So think of your atherosclerotic type of patient having those plaques and calcifications building up on the mitral valve, or those calcifications building up on the chordae tendineae themselves, and that limits the function of the valve itself. But those are chronic things that take a long time to develop. So it's going to be a much older person who's going to develop that form of mitral stenosis. You may be asking, well, what are the secondary consequences of having mitral stenosis? Well, if I have a resistance to opening of that mitral valve during diastole, remember diastole is a low pressure phase of the cardiac cycle, right? And most of the blood that flows from the atrium to the ventricle is passive. To be able to open that valve, I have to generate a much higher pressure. So what does that mean? That then means that the atrium is having to see pressures much higher than usual. And that higher pressure leads to higher volume, because you're not having as much or as long of a diastolic phase to get that volume out of the atria and into the ventricle. So that volume is going to accumulate in the atria, which then means it's going to back up into the lungs and cause pulmonary congestion. And now you're going to have crackles on your exam. But you can imagine if I rely on a higher pressure to get that flow of blood, conditions like AFib, where I lose that atrial kick, can make this condition worse. So this would be the type of patient that when we talk about treatments, we may not want to give them a rate control. We actually may want to do a rhythm control strategy, because we don't want them in AFib, because I need them generating that atrial kick, that squeeze, to just get some flow, forward flow of blood, okay? So what are the symptoms of this? Well, they tend to have like a progressive dyspnea with exertion, reduced exercise capacity because they don't have that forward cardiac output. So those exertional symptoms are there because of that reduced cardiac output. And then they start to have heart failure type of symptoms because all that volume is getting backed up into the lungs, which then can lead to back up into the right side of the heart, leading to right-sided heart failure, leading to things like jugular venous distension, peripheral edema, all of those things that we associate with a right-sided failure. Now, on physical, on auscultation in particular, remember mitral valve, both stenosis and regurgitation, is best heard in the mitral auscultation site. So that fifth intercostal space, mid-clavicular line, right? Well, I'm just going to stop the noise. But the configuration for a mitral stenosis has this decrescendo crescendo type of pattern because initially, when you're trying to generate that higher pressure, in order to just open the valve to get that blood flowing, pressure's building, pressure's building, pressure's building, it finally opens, and it kind of mimics this subway picture where everybody now is trying to get through that tiny opening. There's a lot of turbulence that develops as they're trying to get into that opening. Now, as time goes on, that turbulent flow starts to diminish. So that means that our murmur starts to decrescendo. But what happens right before S1? Your atrial kick, right? Now I'm generating a higher pressure really quickly. Now I'm getting that turbulent flow again, and now that murmur gets louder as that atrial kick gets stronger, generating a higher pressure. Okay? So that's why you get a decrescendo, crescendo pattern associated with mitral stenosis. Okay. On your ancillary studies, so we talked about physical exam findings, let's talk about our ancillary studies. What might we see? Well, if this is a left atrial problem, where now the left atria is dealing with a higher pressure, higher volume, that's going to cause the left atria to get bigger. So on your EKG, you're going to see a left atrial enlargement, or this P mitrale, where remember the P wave, the second part to it is due to the depolarization of your left atria, because it's delayed from the right atrial depolarization. So you're going to kind of get this camel humped kind of appearance to your P wave. Okay. Now, if this is bad enough, and this is chronic enough, and it's going back and it's causing right-sided problems, then you may also start to see right ventricular hypertrophy or a right atrial enlargement as well. Okay. Chest X-ray, if the consequences of this condition is pulmonary congestion, then should it make sense that you may see signs of pulmonary congestion on your X-ray? The answer is yes, right? Your echo is going to be your test of choice. And one of the unique things that you're going to find on your echo is this fish mouth deformity, because as part of this condition, this calcification or whatever, this inflammatory response, this enlargement, this chronic change, all that stuff, is going to thicken the mitral valve. And you can see in the picture of the cross-sectional area of the heart on the echo, kind of looks like a fish's mouth, right? So that's why you get that fish mouth appearance to the mitral valve on echo. Okay. So how are you going to treat mitral stenosis? Well, if this is a volume overload, or the consequences of this condition is a volume overload, let me do things to help minimize that overload. So let's do salt restriction. Limit the amount of sodium that they have in their diet each day. Let's give them diuretics so they're more likely to pee out volume. Okay? Let's try to reduce that excessive preload. If we're going to go back to our physiologic terms, let's reduce that excessive preload so that we can restore a somewhat normal function of the heart the best we can. We also tend to do beta blockers or the non-dihydropyridine calcium channel blockers if they can't tolerate beta blockers, because if I can slow the heart down, I can prolong my diastolic phase, which means maybe I can get a little more volume going into the ventricle from the atria. Okay. So slow down the heart rate, increase that diastolic phase so that we can increase the volume in the ventricle, which then means I increase my stroke volume, which then means I have a higher cardiac output. Okay. But for patients who have severe and symptomatic disease, medications, lifestyle changes are not going to be enough. We're going to have to do a more invasive procedure in order to treat this condition adequately. And kind of the preferred method is this percutaneous mitral balloon valvotomy, which is pictured in the graphic there, where basically I thread catheters, wires, up through the right side of the heart. I punch through the atrial septum, and then I thread that down a deflated balloon through the mitral valve. And once I'm in position, I will inflate that balloon. And the theory is that's going to then rip those adhesions on the valves that's keeping those leaflets together, so that now those leaflets can function independently from each other. Okay, that's the process on how this works. But you can imagine probably some complications potentially being there. One is a residual atrial septal defect because we punch through the wall of the atrium to get access to this, right? The other kind of concerns are if I'm breaking things off of the leaflets with the balloon, what's to say that that calcium chunk, kind of think it was like a kidney stone but in the heart, gets dislodged and sent to the brain. It's going to obstruct blood flow similar to what a blood clot does, right? So it's going to cause a stroke. The unfortunate thing is, TPA is probably not going to help you, right? Because it's a calcium thing, not a blood thing. And then other concerns would be, okay, now you go from a mitral stenosis to now a mitral regurgitation, because now I pop those leaflets open and now they freely move, but that doesn't necessarily mean that they are going to close like they should. So there may be a regurgitation present from this. And then, of course, if you're a little aggressive with moving the catheter, you may punch a hole through the wall of the heart and cause a perforation and rupture of the cardiac border. But that's a much less invasive approach compared to some of our other options. And we're going to visit what our other options are when we get back from break. So let's go ahead, take 10 minutes, come back at 9. Good job.
If it's something that that's really not they can't move it. That's the pain that they can't touch it. There's something in there is preventing a range of motion, and that's that like I don't want to read that. But yeah, but I can't move it to walk my way. Yeah, but they're all like, as far as
They also serve
That's all I know. Not necessarily. No. And the reason why you're necessarily here in a situation is the ventricle itself is fine. The ventricle will pump, yeah, the ventricle will pump anywhere else blood gets treated. The problem is, the ventricle itself is not stiff. Now, you may have pretty, but not so it stops that ventricle because that valve closes.
It's like, here you go, you get after Christmas, you know, like, here you go, Santa Claus just showed up. change, I just put the egg I'll eat it and then throw it away around the house. Yesterday I was like, this broke bother.
It's not like
It's like
All right, let's get back to it. So we were just talking about the balloon valvotomy, and you may be wondering, okay, those complications seem pretty serious. Why would we have that be our preferred procedure in order to fix this condition? And the answer is, the other options we have require an open heart, cardiopulmonary bypass, which both of those are very complex, high-risk procedures, to the point where the mortality rate on the table is going to be much higher than it is if we just did the balloon valvotomy instead. Because we can deal with some of the complications pretty easily with the balloon valvotomy. Like if you have a persistent atrial septal defect from puncturing the atrial wall, we have the ability to put a patch over that hole and fix the problem, right? But if somebody's heart stops unintentionally, or after I intentionally stop the heart to do the procedure, and now it doesn't restart, yeah, that's of course a bad situation. So that's why the balloon valvotomy is the preferred procedure, because overall it's a much less riskier option. Okay. But let's say we can't do the valvotomy, the balloon valvotomy. What can we do? Well, we can do an open heart procedure where now I'm dissecting the valve leaflets to free them up. That would be the open commiserotomy that you see here. Or I can just remove the valve itself and replace it with something else. Just do a valve replacement. And when we have the valve replacement option, we can choose between two options, either a biologic or a mechanical. And there's advantages and negatives to both of these options. So you got to kind of weigh your individual patient's risks, the benefits, and those types of things to help you come up with the correct option for treatment, okay? So what are the advantages of a biologic? Well, first of all, biologics, typically we get them from like pig, we may get them from cow, and we can also get human cadaver values too. Okay, so we've got a couple of different options for the biologic. The advantage of the biologic is if it's biologic live tissue, it is less likely to form blood clots on it. So patients do not need anticoagulation if they have this. So this would be great for your patients. For instance, an elderly patient who falls a lot. Probably not the person you want on an anticoagulant if they fall, hit their head, and now they have an intracranial bleed, right? Let's say you have a younger athlete who does a physical contact kind of sport. Probably not a great person to be on an anticoagulant, right? Let's say you have a woman of childbearing age who wants to get pregnant, probably also not the person you want on anticoagulants, right? So assessing those patient risks can help you determine which one would be better in that patient. The problem with a biologic is the lifespan of it is much less. So you're only talking about 10, maybe 15 years that this valve will be good. And then they're going to have to replace it with something else because it's going to wear out, okay? So a lot of times we wait or we give the biologics to older patients who can't tolerate the anticoagulation, but also their life expectancy is that they probably are going to die of other things before that heart valve wears out, okay? So that's the classic kind of person who gets that biologic heart valve. But that's not necessarily true in all cases. You've got to individualize the therapy to your patient. The mechanical heart valve, the advantage of it is it lasts so much longer than the biologic, like in the case of the news story where it lasted almost 50 years. And she could have gone on longer with those heart valves if it wasn't for the other things wrong with the heart kind of finally caught up and necessitated a heart transplant for her, okay? But it wasn't necessarily the valves started to malfunction leading to the heart transplant. So much longer lifespan, so maybe the type of patient that you want to put this in a younger person so that you're not having to go do valve replacement surgeries every 10 years starting in their 20s or 30s, right? Let's give them something that lasts longer. The problem with the mechanical heart valve is this is a foreign substance, a foreign body, right? Increases risk of infective endocarditis. We talked about when you're assessing high risk for it, you're thinking of people with artificial heart valves. But your body, that surface of that mechanical valve is much more likely to form blood clots, which then forming blood clots on a structure that then gets sent downstream can lead to things like strokes or other peripheral arterial occlusions, similar to like mesenteric thrombosis. So you gotta, that's the main concern, which means then to treat and address that risk, they need to be on lifelong anticoagulation. So is lifelong anticoagulation appropriate for that patient or not? You have an 80-year-old who falls, one, their life expectancy is probably not going to be more than 15, 20 years, so it's probably not the right patient. If they're falling a lot, probably not the right patient to be on an anticoagulant. So that elderly person is probably not the right patient to do a mechanical heart valve in. So knowing the advantages and disadvantages of both approaches is important. Not necessarily from a primary care standpoint, meaning like you're the one that's going to decide which valve gets placed, right? The surgeon's going to do that. But there are implications that you as a primary care provider are going to have to know. If they have a mechanical heart valve and they are on an anticoagulant, you can't just stop that, right? You've got to continue that. If they want to stop it, you at the primary care level are not the correct provider to make that decision. You're going to want to send them to the cardiothoracic surgeon to have them weigh in on anticoagulation and whether or not maybe needing an alternative heart valve and those types of things. So, but at a primary care standpoint, you need to continue their anticoagulation. Okay, I think we kind of covered this slide. So that's mitral stenosis. Any questions about mitral stenosis? Mitral regurg. So remember, regurgitation occurs when the valve should be closed. Should be closed. This is a condition that is more common in women than in men. And when we talk about any regurgitation valvular disease, we have to talk about primary and secondary causes of this, okay? Primary problems are the valve leaflet or its components, so like the chordae, are the problem, okay? So it's the valve leaflets that are diseased. When we talk about secondary causes of regurgitation, we're now talking about structures outside of the valves are the problem that leads to damage or leads to the valve not functioning properly. An example of this would be dilated cardiomyopathy, which we're going to talk about in this block. What happens is the ventricle gets separated. The ventricle gets larger in diameter, and that process of that ventricle getting bigger pulls those valve leaflet components apart, leading to that regurgitation. Okay. So that's an example of a secondary cause. Okay. From looking at the primary causes of mitral regurgitation, we're looking at mitral valve prolapse being kind of the most common in the US, and mitral valve prolapse is more common in women. So when we said that this is more of a female predominance, this is why, because of that mitral valve prolapse component to it. But it could be infective endocarditis. So the valve leaflets have that vegetation on them, or they're eating through the valve itself, creating a hole. Or it could be trauma related. Okay. Secondary, we talked about the causes of that. Another thing would be like ischemic heart disease, other causes of like a heart attack leading to large regions of the left ventricle that are damaged because of it. And this can lead, mitral valve regurgitation can lead to elevated pressures in the left atria, left ventricle, and then it can lead to reduced cardiac output. Okay. So those are the consequences of it. And the severity of that regurgitation is going to be kind of based on 5 things. So what's the size of the opening during regurgitation? So is it the little pinhole, or is it the entire surface area of the mitral valve is open? So what's the amount of volume that can actually go through that opening? What's the systolic pressure grade between the left atrium and the left ventricle? If left ventricle pressure is 100 and the pressure in the atria is 1, you have that delta of 99 millimeters of mercury. Does it make sense path of least resistance is to flow from the left ventricle into the left atrium because of that pressure differential, right? But let's say the pressure differential ventricle is 50, and the pressure in the atria is 45. Now you only have a 5 millimeter mercury difference. You're going to have some flow, but it's not going to be as much as if there was a 99-point difference in that gradient. So what's the pressure difference? And then the other option is, what's the vascular resistance for that forward flow? So if I have aortic stenosis, which we'll talk about tomorrow, or I have hypertension and now my systolic blood pressure is higher, my diastolic pressure is higher, so that I need more pressure to open that aortic valve to get that blood flowing out that way versus going into the atria, that's going to affect how much volume regurgitates as well. Left atrium compliance, so how willing is the atria to take on that volume? If it is stiff and non-compliant, just a little bit of regurgitant volume is going to quickly raise the pressure. But if that atrium is very compliant, now it takes on all that volume, then you're going to have lower pressures for an extended period of time, leading to more regurgitation going to the atria versus out through the aortic valve. And then the duration of regurgitation. So is it full duration of diastole, or is it only mid-systole, even a late systolic kind of regurgitation? That's going to impact how much volume could regurgitate there. When we look at the pathophysiology, or the pathophysiologic effects of regurgitation, we have to also consider acute problems and chronic problems. And the difference between the two is whether or not the heart has the opportunity to develop compensatory mechanisms to deal with those physiologic changes, okay? So in an acute setting, let's say it's from patient has a heart attack, knocks out the papillary muscles, and now you just have a valve leaflet just kind of floating in the breeze. That's a quick on. The heart has no opportunity to compensate for those physiologic changes. So that's going to lead to a very serious condition developing quickly. Okay? Chronic regurgitation, on the other hand, it's a slow process. The body develops those compensatory changes to be able to tolerate those physiologic changes. So now the presentation is not going to be acutely problematic. Chronic changes are going to develop, which then leads to further chronic changes, which then can lead to pretty significant conditions. But the presentation is going to be very, very different if this is an acute mitral regurg or if this is a chronic mitral regurg. So in the acute setting, you're having a high volume quickly going into the atrium. The atrium hasn't developed the compensatory mechanisms to take on all that volume. So that means it's going to be less stretchy. So it's not going to take on that volume, which means pressure is quickly going to rise in the left atrium. And that high pressure, high volume then leads to backing up into the lungs and leads to like a flash pulmonary edema kind of picture. Okay. Now the other thing is, because you have all that high volume going to the atria, you're losing that forward output. So now you're having a reduced cardiac output that may not meet the demands or the needs of the body, i.e. maintaining an adequate perfusing blood pressure. So if I'm not perfusing the organs correctly, I can't maintain a diastolic pressure that's adequate to even perfuse the heart and the coronary arteries themselves. Imagine what the consequences are going to be of that. Okay? So in the acute setting, be thinking of flash pulmonary edema and be thinking of forward flow problems. In chronic mitral regurg, I now give time for the heart, or the left atrium in particular, to develop compensatory changes to tolerate these physiologic changes. So now, instead of having a stiff, non-compliant left atria, I now have developed the processes to be more stretchy, which means the left atria will take on higher volumes, and because it has that stretchiness, that pressure is actually going to remain maybe normal, high normal, for a more extended period of time because that atria is willing to take on that volume. So you have much less of a pulmonary congestion concern in chronic mitral regurg, but you have a more concern of a cardiac output because you have more volume backing up than going out through the aortic valve and into the systemic circulation. So the presentation is going to be different in a acute mitral regurg versus a chronic mitral regurg. So what are you going to see on as far as symptoms? So pulmonary symptoms related to congestion, especially in the acute setting. You're going to see the exertional symptoms because of the forward flow problem. Because of these increased strain and stress that's being put on heart structures, arrhythmias are going to be more likely to develop, like AFib and those types of arrhythmias will be much more likely they are present. On your physical, in the acute setting, you're going to have an early to mid-systolic decrescendo quality, but in a chronic, it's typically this holosystolic murmur. Let me just advance the slide so I can stop that murmur. But now the reason that you have this difference in the acute and chronic version is, remember, in the acute setting, what's happening to pressure in the atria compared to chronic? The pressure is rapidly increasing, so you're going to quickly get to a point where you're going to have almost like an equilibration between the atria pressure and the ventricular pressure, so you're going to stop that flow going from ventricle to atria. Okay? So that's why you get kind of that early to mid-systolic murmur with a decrescendo pattern, because that pressure is rapidly increasing and that flow is going to decrease. Okay? But in the chronic presentation, now that atria is stretching, it's compensating for that volume, that pressure remains low, so that encourages more of a flow for the full duration of systole. Okay? So that's why you're going to see that holosystolic murmur in chronic mitral regurg. This is a mitral valve disorder, so best heard at the apex of the heart. If we do dynamic auscultation maneuvers, if we do hand grip where we're increasing afterload, it's going to make this murmur worse, because if I have more resistance to open the aortic valve, I am encouraging more of a regurgitation. Okay, so the grip increases the murmur present in this disease. Okay. You may see some other things on physical exam other than the auscultation, but these are not as important as that auscultation finding. With your ancillary studies, because this does affect the left atria, you can see that P mitrale again, okay, similar to the mitral stenosis. What is different, though, is you can see left ventricular hypertrophy in mitral regurg, where you don't see that in mitral stenosis. Because the ventricle in mitral stenosis is normal. It will squeeze whatever blood gets to it, right? But in this condition, because of that regurgitation, it's going to affect the physiology of that left ventricle, which is going to then lead to changes developing in the left ventricle. Okay. Echo is going to be, of course, your test of choice. It's going to be able to give you a lot of information about function, the degree of regurgitation, and a lot of other information with that. But when we come to treatment, though, we've got to consider, is this an acute form? Because remember we said pulmonary congestion, flash pulmonary edema is the concern in an acute regurgitation. I'm going to need to do things to deal with that. So doing things like reducing the afterload, so I'm trying to encourage more of a forward flow than a backwards flow. And then I also may need to do some more invasive type of procedures like an intra-aortic balloon pump or other mechanical circulatory support kind of things while I prepare them to go to surgery to fix the valve. Okay. If it's a chronic thing, remember chronic is more of a cardiac output problem. I need to do things to maintain a function and encourage more of a forward flow or more of a cardiac output versus a regurgitant flow. So you're looking at doing things like ACE inhibitors, beta blockers, and aldosterone antagonists because you're trying to prevent the development of those compensatory changes, right, that can lead to further decline in the cardiac function. And then we may, especially if it's a primary problem, so the valve leaflets are the problem, then we may need to go in and replace the valve as well. Okay. Now let's talk about mitral valve prolapse, and this is discussed separately from mitral regurg because not all mitral valve prolapse leads to mitral regurg. However, the most common cause of mitral regurg is mitral valve prolapse. Does that make sense? So, most common cause of mitral regurg is mitral valve prolapse, but not all mitral valve prolapses lead to mitral regurg. Okay. Because when we look at what the definition of mitral valve prolapse is, it's really just an excessive backwards movement of the mitral valve. And particularly, you have at least a 2 millimeter kind of ballooning backwards into the atria. That ballooning, that increased stretchiness, may not lead to an opening of the valve. So you won't necessarily have a regurgitation. But it could, if that billowing, that excessive billowing, does lead to opening of the valve, then you can get that regurgitation present. Mitral valve prolapse is present in about 2% of the population and is more common in women. Okay? But not everyone is going to have regurgitation associated with it. So it could be genetic related, that's why you have it, but it could also be if you have like a connective tissue disorder like Marfan's or Ehlers-Danlos, that's going to make you more likely to have this because you're going to have that increased elasticity of the chordae tendineae leading to that excessive billowing of the mitral valve. Okay. And most commonly, these patients are going to be asymptomatic. Okay, so they have no idea that they have this condition unless you auscultate it and then tell them you have mitral valve prolapse. Okay. If they do have symptoms, okay, maybe non-specific kind of things, but it could also be related to if there is regurgitation present, what's the degree of regurgitation that is occurring? Okay, if it's just a little bit, may not know anything's wrong. If it's a lot of regurgitation, then think about the symptoms we saw with mitral regurg, and that's how they're going to present, okay? But the classic finding of just mitral valve prolapse is this mid-systolic click, okay? So you're going to hear a click. Now, if they have a regurgitation component to their mitral valve prolapse, then you can hear the regurgitation murmur, which would be a late systolic murmur. Okay. So you're going to hear that click, and then if they have regurgitation, late systolic flow murmur. And what's interesting, actually, if you are questioning if what you're hearing is correct and that this is mitral valve prolapse with a regurgitation, is we can do some dynamic maneuvers to alter when you hear the murmur and help you kind of differentiate it. And what happens is, so this is just the murmur, you're going to have that mid-systolic click with a little bit of a regurgitation murmur. Advance, then go back. But in your dynamic maneuvers, what happens is, let me decrease my preload by standing or doing a Valsalva, and what happens is that click comes closer to that S1. And you may be wondering, well, why is that? Well, if I decrease the volume, my preload, I reduce the stress and strain and counter resistance on the chordae tendineae. So that means that that excessive billowing is going to occur much earlier in the cardiac systolic phase because I don't have that counter resistance of that pressure and volume putting strain and stress on the chordae tendineae. So reducing preload moves it earlier. If I increase my vascular resistance, so I increase if I increase my venous return, so I'm increasing my preload by squatting or doing leg raises, what happens is now I have all this extra volume in the ventricle, which means then I have, because of that stretch, I'm putting more strain and counter resistance to those leaflets to billow back. Because my chordae tendineae, which are hyperelastic, right, are being stretched out further, so they're having a higher counter resistance to prevent that billowing of the leaflet. So you're going to see that delay in the murmur, the click in the murmur. Okay, so just affecting or changing the preload will change the timing of this murmur. Okay, does that make sense? So it really just comes down to volume and stretch and counter resistance or pull on the chordae tendineae themselves. On your EKG, when we look at ancillary studies, may not find anything abnormal on it. If there is a mitral regurg present that is leading to atrial enlargement, then yes, you may start to see some changes with it. But for the most part, it tends to be normal. Same goes with chest x-ray. For the most part, asymptomatic. If that mitral regurg is bad enough, then yes, that could translate to pulmonary findings, but not very common or not necessarily something you'll see with everybody with mitral valve prolapse. Echocardiogram, study of choice, because it looks at the internal function and the valve function themselves. You'll be able to detect that 2 millimeters or more billowing of the mitral valve, but then you can also put on Doppler to see if there is a regurgitation present to it. Okay. How do we treat this? Well, if they're asymptomatic, then you're not going to treat it. Just reassurance, we'll just watch it, make sure it doesn't get worse, kind of thing. But if they're having severe regurgitation, and especially if it's causing symptoms, then we're going to treat it like we did with a mitral regurgitation valvular disorder and go in and look at doing things like valve replacements and those types of things. But one other topic I wanted to kind of highlight in this, because you may encounter this in your practice, is prior to 2007, mitral valve prolapse was a criteria to do prophylactic antibiotics before high-risk dental procedures. So from an infective endocarditis, we used to give prophylactic antibiotics for this condition. But in 2007, the American Heart Association came out and said, you no longer need to give prophylactic antibiotics for patients with mitral valve prolapse undergoing high-risk dental procedures. So you don't need, this is not a condition that warrants those prophylactic antibiotics. And you think about it, okay, 2007 was almost 20 years ago. This is still something you're going to see in your practice, okay? My own mother, who's 77, until last year thought she needed prophylactic antibiotics before she went to see the dentist. And her providers kept giving her that prophylactic antibiotic because she was told prior to 2007 that she needed to tell her provider if she was undergoing dental procedures that she needed those antibiotics. So something you may encounter that is no longer a thing. And it's been almost 20 years since it's been no longer a thing. Okay. Questions about what we talked about? Okay. I will see you all tomorrow, and we will continue our lecture on valvular heart disease, heart diseases.